I'm Carrie Shinstock. I'm from the Department of Nephrology and Hypertension here at Mayo Clinic. In the February issue of Mayo Clinic Proceedings, my article, Thinking Beyond Clinical Guidelines, an Update in Hypertension, will be published. As most of you know, hypertension is one of the most common conditions encountered by the primary care physician, and it leads to multiple comorbidities and other health problems. But despite these problems, organizations have had difficulty establishing the optimal targets for blood pressure. In this article, I will discuss the controversy around, or the debate surrounding defining the optimal blood pressure targets, and also talk about other important topics in hypertension. In early 2014, the 8th Joint National Committee suggested new hypertension targets. Specifically, in elderly adults, those patients greater than age 60, without chronic kidney disease or diabetes, it is recommended that the optimal target for blood pressure be less than 150/90. Without chronic kidney disease or diabetes in these patients, it's recommended that blood pressure target be less than 140/90. What's important to remember is that these targets are just suggestions. They're not a substitute for good clinical judgment. Furthermore, what's really important is that as a clinician, you make sure that you have reliable and accurate blood pressure readings. In the office, it's important that the patient has not been smoking or drinking caffeine within 30 minutes of the blood pressure, and that the patient has been resting at least 5 minutes. Optimally, the blood pressure would be taken by a nurse or a care provider other than the physician. It's also optimal that the average of 3 to 5 readings taken 1 to 2 minutes apart be done. Also important that the blood pressure be taken at the upper arm instead of the wrist or finger. It's also really important that patients are educated about how to take blood pressure at home, because actually home blood pressure readings are more reliable and accurate than office readings. I would use the same technique that is recommended in the office. Make sure that the patient is doing an upper arm cuff if possible, and avoid wrist cuffs and finger cuffs that are readily available at the outside. Universal cuffs taken at the pharmacist are often not reliable, and I would discourage these use. In select settings where office readings are thought to be unreliable, such as in white coat hypertension or masked hypertension, if the patient's blood pressure is uncontrolled despite increasing medications, if the patient has autonomic insufficiency, or if the patient is referred to a hypertension specialist, ambulatory blood pressure readings are recommended. This is when blood pressure is taken every 5 to 10 minutes over 6 to 24 hours. Overall, my main point in the paper is that new suggestions or guidelines for optimal blood pressure targets have been recently published, but make sure that these are not a substitute for good clinical judgment and you get accurate and reliable blood pressure readings on your patients.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.